Go.
Right, my name's Daniel Parkhanal, maxillofacial registrar, and Prakash Patel, one of our fellows, head and neck fellows, here for a couple of years. So the purpose of this demonstration will be a screening maxillofacial trauma presentation for the purposes primarily of accident and emergency doctors. As with any examination, there'll be as with any screening examination, there'll be areas that you can pick up on if there are abnormalities detected and interrogate further. So we're assuming again that if this is a polytrauma patient in an ATLS scenario, that the priorities, the airway, the C-spine, breathing, circulation, have all been considered. And we're just going to focus in on the maxillofacial specific examination. Okay, so essentially what I do is top to bottom, we're going to classify this examination to the upper third, middle third and lower third, and all that can alternatively be discussed in terms of the zygomatico orbital regions, the mid-face including maxilla, and the lower third, which is predominantly examination of the mandible. So a sweeping examination of the scalp itself, looking for any soft tissue injuries, and again they can be further elicited and neurovascular status assessed if there are any found or anything concerned. Looking briefly behind the ear for any posterior to mastoid region bruising, giving you an indication of any possible skull base injuries with bruising within the mastoid process and air cells, which is commonly known as Battle's sign. And back to the front. So again, just feeling the supraorbital ridges for any obvious bony steps or deformities. At this stage, I tend to ask the patient to just raise their eyebrows, just have a global feeling for the frontal branch of facial nerve. Good. And then around the orbital margins, so superior orbit, lateral orbit, this is the region of the zygomatico frontal suture coming down, orbital floor. This is where you would feel a step if there was an orbital floor or orbital fracture, of which there's not. So more specifically, the zygoma. Zygoma comes from zygon, meaning yolk, and has a zygomatico temporal join, a zygomatical frontal suture around here, and then articulates with the maxilla here at the zygomaxillary buttress. We know that there's a infraorbital foramen about a centimetre below the lid in the mid-pupillary line, and that commonly with the zygomatic region or zygomatic orbital complex injuries, you get paresthesia off the cheek and the distribution of the infraorbital nerve, side of nose, top lip, and an odd sensation the patient complains of in the upper teeth in that quadrant. So once we've assessed that, I'll briefly ask if there's any sensory disturbance comparing left with right.
No.
Anything obvious there at all? Good. Focusing still on the zygomatic injuries, sometimes there'll be an obvious depression, especially if there's an isolated arch fracture, and that can be detected from the front-on view, but as with anything, it's good to get views from the top. And you can stand behind to do this. I'm being lazy from a filming point of view just to try and not get in the way of the camera, but again, asymmetry there.
Do you want to just show us
malar prominence? Okay,
how you set it from behind? So it's quite important to see if there's any asymmetry.
Head back.
Of the cheek projection.
So looking at two things from here. One is the arch itself, to see if there's any obvious deficits. Also looking at the malar prominence, so where that zygomatic bone comes round the front, that junction between the anterior face and the lateral bit is the malar prominence. I put my finger, again gently make sure there's no pain on the patient, and assess that, see the fingers are at a similar level, trying to exclude any soft tissue involvement which can draw the eye unnecessarily, and that looks fine. And again, while you're here, you can look at the nose, you can look at the supraorbital regions and the frontal any frontal bone asymmetry.
The only other thing I'd add is you can look at enophthalmos of the orbit as well.
Yeah.
So tipping the head back is a good point to see whether the projection of the eye ball itself, whether it's proptose or enophthalmic. Yeah.
And focusing on the zygoma still, so we know that by definition, if you have a blow to the zygoma, there will be, by definition, involvement of that zygomatico maxillary. There'll be orbital involvement. What you won't find clinically, but you often see in a CT scan, is that zygomaticosphenoidal suture buckling. So the symptoms, what you see in a patient who has a zygomatic complex injury, there are a few things, one of which is reduction in mouth opening. The reason being, so if I ask you to open your mouth, good, so it's good mouth opening. The reason for that is twofold. One is the purely mechanical problem where the zygomatic arch is depressed, and that big temporalis muscle which inserts onto the coronoid process of the mandible beneath the arch is impinged, and they physically can't move that temporalis up and down. The second thing is that the masseter muscle, the deep head masseter muscle, inserts on that inside of the zygomatic arch, which also have an impact on their mouth opening. The second thing we mentioned was some paresthesia. So again, that can sometimes happen with zygomatic complex injuries, but more commonly with orbital floor injuries. There may be a step, and we've mentioned the cosmetic deficit.
Okay, do you want to go through the eye signs, and we'll do the midface as a separate video? So eye features and signs in zygomatic fracture.
So one of the purposes, one of the functions of the zygoma is for protection of that globe from glancing blows to the side. So aside from there being a cosmetic periorbital defect from a zygomatic injury, it also does offer some functional deficit if you have zygomatic arch depression, zygomatic lateral orbit depression on that side. So more specifically on the orbital fracture point of view, the common orbital fractures that we see and that will certainly be seen in A&E will be orbital floor injuries.
Yeah.
Blows to the eye. Common clinical signs of that will be restriction of and entrapment of the inferior rectus muscle, which is easy to elicit in a patient. Firstly, they'll complain of double vision, and on looking upwards, so no restriction, there'll be restriction of gaze in the direction of opposite to the muscle entrapped. We can talk about an orbital fracture in greater detail.
So full range of eye movements, periorbital ecchymosis, subconjunctival hematoma with no posterior border. Do you want to demonstrate that for me?
Yeah, so clinical signs of an orbital floor fracture would include a periorbital ecchymosis, and the key thing with this periorbital ecchymosis, which differentiates it from a simple bruising around the eye, is that you often get this very sharply defined junction between bruising and unbruised skin. And the reason for that is that any bruising inside the orbit is restrained by the orbital septum. So the orbital septum is essentially the diaphragm of the eye, pierced by the upper and upper lower lids. And it's that diaphragm of the eye, the orbital septum, that stops any bleeding from exiting the orbit. So you get this beautifully defined periorbital ecchymosis, which is a pretty strong sign for an orbital fracture. The second thing is a subconjunctival hemorrhage, but as Jag alluded to, that doesn't have a posterior limit. So you may get subconjunctival hemorrhage from direct trauma to the eye itself, but if that is tracking posteriorly, it implies that it's come from within out rather than reverse, and again is a sign of an orbital fracture.
And the range of movements?
Range of movements. So again, a screening test asks patients to look forward at the finger, ask them if they can see one or two fingers at that point, and then the idea being sort of 9 fields of gaze, crudely, admittedly, is so up. Okay, so it's then asking if they see 1 or 2 fingers at that stage. And I deliberately changed the orientation of my finger to horizontal on vertical gaze because it's easier to distinguish between two fingers and one finger than if it was vertical. And moving down, up to the middle, and then moving to the sides. So it's nice, smooth movements. Try not to push patients too far to one side because everyone will have some degree of diplopia at extremes of gaze. Okay, good. And then up to the corners. All right. Good. And then also down and out. And it's just useful to revise your extraocular muscle anatomy and innervation of them. The entrapment that we commonly see will be lateral rectus restriction because of medial rectus entrapment from medial walls, less commonly than inferior rectus entrapment from orbital floor injuries when the affected eye will not be able to look upwards, and your brain cannot compensate for those two differences in gaze, and they'll complain of double vision.
Okay.
If there is diplopia complained of in the absence of restriction, then it's not commonly seen acutely, but certainly differences in the AP projection of the eye. So with enophthalmos, to a lesser degree, exophthalmos, there will be it's a possibility of getting double vision in that case as well. Right, so we can come back and do more specific orbital examination at another time, but we'll move on to a
Should we stop at
midface.
that and then? Yeah,
Yeah.
we'll stop that. Thank you.